Hello, my name is Evangelos Terpos. I'm an assistant professor of hematology in the University of Athens School of Medicine, Athens, Greece. I'm here in Paris for the International Myeloma Workshop, and with my colleague Dr. Nupur Raje, we are going to discuss the session that was just finished about the practical aspects of bone disease in multiple myeloma. Okay, in this session, first of all, Professor Thanos Dimopoulos presented the data about imaging in multiple myeloma, confirming that every doctor has to focus on the International Myeloma Working Group guidelines regarding imaging, meaning that all patients with multiple myeloma diagnosis have to have a skeletal survey using conventional radiography. And with this technique, approximately 70 to 75% of patients are going to have lytic lesions or diffuse osteoporosis in the conventional radiography. For the other patients, all of them, 20 to 25% of the patients, need to have a whole body MRI in order to see if there are any focal lesions or diffuse pattern that can put them in the high-risk group and have rapid progression to symptomatic myeloma. So, using this technique with the whole body MRI, approximately 50% of patients with normal conventional radiography have abnormal findings. Another very interesting study was presented by Dr. Jimsing from the Nordic group. In this study, they compared two doses of pamidronate, 30 versus 90 milligram intravenously every month, and they've shown that both regarding reduction of skeletal-related event, time to first skeletal-related event, progression-free survival, and overall survival, even if the patients received conventional treatment followed by autologous transplantation or conventional treatment without an autologous transplantation, the two doses were found to be equally effective. So the authors from this study suggest that we have to use 30 milligram of pamidronate instead of 90 milligram because it has a lower renal toxicity and lower incidence of ONJ with similar efficacy with the standard 90 milligram. Another very important study was presented by Tony Child, the MRC9 study comparing zoledronic acid and clodronate. And this study showed that zoledronic acid not only reduced the incidence of skeletal-related events compared to clodronate dramatically, 27 versus 34%, but also it increased overall survival of the patients approximately for 5.5 months. So it seems that zoledronic acid has also an anti-myeloma effect. And another important finding of this study is that even patients with no lytic lesions on conventional radiography had a reduction, approximately 50% reduction of skeletal-related events compared to oral clodronate. Finally, I presented data about the role of bone markers in multiple myeloma, and we and others have shown that bone resorption markers like urinary NTX, serum CTX, and serum ICTP can accurately reflect the extent of bone disease and also have prognostic value for multiple myeloma patients. A very important issue is if using these markers we can increase the intervals between zoledronic acid or pamidronate administration, meaning if we manage to reduce the markers after a specific number of cycles of zoledronic acid or pamidronate, if then we can increase the interval between the administration doses. And a second very important finding is that at least 2 months before the progression of the disease, serum CTX is elevated, and this is very important. Finally, we showed the results of the effect of the different novel anti-myeloma agents on bone markers, and we have shown that thalidomide can reduce bone resorption but has no effect on bone formation, both in newly diagnosed and relapsed refractory myeloma, while bortezomib reduces bone resorption but also increases bone formation, and this increase is dramatic, and also it is translated to an increase in the bone mineral density of the patients and the bone volume of the patient using micro-CT measurements. On the other hand, lenalidomide seems to have very minor effect on bone resorption and no effect on bone formation. And we had a randomized comparison between RD and VRD, and we have shown that in the RD arm we had an increase after 6 months of therapy of DCOP1 protein, which is an osteoblast inhibitor. When Velcade is into the study, then we had a dramatic reduction of DKK1 as in the study than Velcade was used alone. Furthermore, regarding bone formation markers, the combination of Velcade with lenalidomide dexamethasone increased dramatically both markers of bone formation, osteocalcin and bone alkaline phosphatase, while RD alone had no effect or reduced a little bit these markers. So in conclusion, I think that it was a very interesting session suggesting that new studies are needed in order to see if using either imaging techniques like MRI or bone markers, we can define more accurately complete response, or we can use them in order to define patients with asymptomatic myeloma but at high risk for progression. Thank you.